Okay, so today we're going to talk about headaches. Headache is unique in medicine for a very important reason. Most symptoms that doctors deal with refer to pathology, and the symptom is an alarm or a sign that indicates pathology. But in headache, indeed, the pain in the head can be a symptom, meaning that it indicates pathology within the nervous system or outside the nervous system. For example, meningitis, subarachnoid hemorrhage, and what have you. In addition, it can be a disease on its own. So it's very unique in that sense. If you look at any other symptoms, whether it is cough, hemoptysis, abdominal pain, joint pain, almost all these symptoms, in fact, all these symptoms are referable to some sort of pathology. It's either a benign pathology or a sinister pathology, but it's always a pathology. But in the case of headache, the pain on the head could mean something sinister or something benign. And it could be a symptom of that. On the other hand, it could be not a symptom at all. It's just a disease of recurrent pain on the head. So if I were to draw an analogy, it's like having an alarm in your house, a fire alarm in your house that rings whenever there's fire. It's good because you'll wake up and put out the fire. But occasionally, the alarm itself is faulty or it's altered in its sensitivity so that it rings when there's no fire on its own. So therefore, you need to come up with a system by which you will decide, when will I wake up and look for the fire and put out the fire, or when will I ignore and go to sleep? Because if you were to make the wrong decisions with regards to one of these, then what's going to happen is either you would be waking up all the time and never go to sleep because the alarm is ringing all the time because of its faulty nature. Or on the other hand, you may fall asleep when there's a true fire. Okay. So with that kind of overview, you realize that you can't have a very naive, simplistic, gut feeling related approach to headache. Because it's a fairly complex clinical problem, you need a formula. Okay. And the formula is what I've given to you in your notes. It's basically 3 questions. If you open up your Word notes that I've sent to you, it's in Word format. You realize that there are 3 questions that you need to ask. And the 3 questions will then give rise to a certain set of possibilities and probabilities. And then based on the probability and possibility, you then decide whether you want to treat this patient's complaint as a primary headache, okay? Or do you want to go look for a secondary cause because you think this is not a primary headache syndrome. This is actually a symptom. The alarm is ringing because there's fire somewhere, okay? And depending on the index of suspicion for the fire, you would either choose a very simple test on the right-hand side or a more sophisticated specific test if your index of suspicion is very high, okay? So with that, let me just quickly go through what I mean by the 3 questions. So the first question is what I refer to as the headache profile, okay? So while talking to you now, if I suddenly start wheezing, I'm sure many of you will be wondering, why am I wheezing? And if I were to tell you that I have a history of asthma, your alarm, the fact that I'm wheezing is going to be less because you know, oh, this patient has a recurrent condition characterized by recurrent wheezing, namely asthma. Therefore, this patient is likely to have an exacerbation of asthma, correct? But on the other hand, if I were to wheeze for the first time ever in my life, at my age, you'd be wondering, oh my God, why is he wheezing? Is he having some kind of airway obstruction, right? So the same way, whenever a patient comes to you, always try to discern. Although the patient is obsessed about the current headache, always try to figure out what the patient's previous headache is. And if the patient has got a recurrent primary headache syndrome, or rather recurrent headache that is characterized the characteristics, or rather fulfills the characteristics of a primary headache syndrome, then you're less likely to worry about a secondary headache now, right? I'm not saying it can't be, but you're less likely. On the other hand, if the person never had a headache ever in his life, it comes to you for the first time. But of course, it could be the first onset of a primary headache syndrome, first onset asthma, for example, or it could be a secondary headache. So it's important to get that. Now, in our local context, and there will be some foreigners in the audience, I'm sure, in our local context, you must learn some of our Singlish terms. So one of our Singlish terms is usually for whenever you ask the patients, do you have migraine or any of this of other history before? Almost all the time, I'm telling you over my years of work in internal medicine, almost all the time our patients will tell you, no, doctor, I don't have migraine, but I have normal headaches. Okay, so normal headache is a Singlish term for migraine or some kind of primary headache syndrome. Most of the time it's migraine. The reason is because unlike you guys who are now being taught about how to approach headaches, many of our previous medical students were never taught headaches systematically. So many times doctors go out and run a practice in primary care without understanding that migraine is actually a very common phenomenon in the general population. Up to 30% of the population has migraine of some sort. Many of you have migraine, and many of you may have been dismissed by your primary physicians as don't worry, this is just normal headache. You know, but if you think about it, what is a normal headache? I mean, why would somebody have recurrent headaches? There must be a reason, right? It could be but basically, I think it's a Singlish term to refer to. It's not a sinister headache, right? But it's still important because migraineurs suffer a lot. So it's important for you to think about the characteristics, characteristics of this headache and see whether it fits into one of these animals. Is it a migraine animal? Is it a tension type animal? Is it a cluster headache animal? Is it a trigeminal neuralgia animal? I use the term animal because, you know, when we look at various animals, we describe animals based on its characteristics, right? So it's good for you to know what are the key characteristics. So you don't have to commit everything to memory. There is a very good website that you can bookmark in your phone. And if you just click on this link, it will give you nice slides like this. For example, migraine without aura is at least 5 attacks a year, often unilateral, throbbing headache, often intrusive, often difficult to continue working. If you continue working, it's because you have to work on that day. And usually they are type A personalities, so they want to continue working. They often find that noise, sound, smells, all these things are irritating at that time. Often relieve a little bit with caffeine, but often caffeine withdrawal makes the headaches worse. Sometimes these patients will tell you that they are sensitive to certain stimulus like sleep deprivation, red wine, and things like that, you know. So, and often worse during menses, much more common in women. Often there's a strong family history. Often the family will also be labeled as normal headaches. So just be wary of that. Okay. So don't when the patient says, I don't have a primary headache syndrome, I got no headaches before, doctor. It's the first time ever. Take it with a pinch of salt. Okay. So I always ask indirect questions like, have you taken time off from work because of headaches? Have you seen a doctor because of headaches? Do you carry analgesics in your bag or in your pocket? Okay, so that's been a validated question for patients with primary headache syndrome, especially if they're overusing analgesics. Okay, anybody who carries paracetamol or analgesics in their handbag, often I use the word handbag because I'm not being sexist here, but most migraineurs are females, and if they carry paracetamol in their handbags for headaches, it often indicates that there is an element of analgesics overuse headaches there. So be wary of that. So don't answer this question as no primary headaches in the past unless you have given due consideration to the fact that the previous primary headache syndrome may have been misdiagnosed or underdiagnosed. Okay. So after you have confirmed that the person has got a primary headache syndrome in the past, then the next question is basically to ask questions that suggest that this is actually a symptom, that fire, there is likely a fire. This is likely to be a secondary headache, the current headache. So now you tell the patient, okay, now tell me about your current headache. Okay. And then just to be sure that you don't miss out things, I always feel it's important for you to have a checklist. So have 5 questions. Okay, 5 questions. 5, you remember 5? Go through the checklist. Later on, we'll talk about the importance of checklists in clinical medicine. If you go through the 5 questions, you're less likely to make errors. If you don't remember there's 5 questions to ask, you may remember to ask, you may just ask 4 questions and you'll miss out one, and then you'll get into trouble. So what are the 5 questions? Very simple. Okay, symptoms and signs of focal neurological deficits. So doctor, this time my headache is associated with double vision. Headache is associated with blurring, slurring of speech. Headache is associated with weakness of one side of the body. Clearly, this indicates that this is not a primary headache syndrome. This is a headache is a symptom of underlying pathology. So this is the fire alarm ringing because there's fire somewhere. Okay. Now, if again the patient says headache, or the family member say this headache is associated with loss of consciousness or obtundation of sensorium, this again is inconsistent with a primary headache syndrome. Okay. Then symptoms and signs of raised pressure, for example, vomiting, headaches that get worse when you lie down or when you're straight. So again, a lot of migraineurs will tell you they vomit when you have headaches. But that's for migraineurs, right? But if you don't have a history of migraine and you're complaining that for the first time ever you're having headaches and it's associated with lots of vomiting, that indicates that there's raised pressure. Some of the lesser known symptoms of raised pressure is transient blackening of vision on both sides, not loss of consciousness, and transient blurring of vision on both sides. That's not usual, but if they do complain of that, not a syncopal feeling, a feeling of loss of consciousness. Sorry, not loss of consciousness, which is syncopal feeling, but just blurring of vision, blackening of vision on both eyes. That could also again indicate raised pressure. So remember to ask this question. Number 4 is constitutional symptoms, namely symptoms suggestive of meningitis. It's very rare that a meningitis patient will just come and tell you headache. They will have constitutional symptoms like fever, anorexia, muscle ache, body generalized discomfort, that kind of symptoms. So look out for these. And then finally, some characteristics of headaches are unusual for primary headache syndromes. So these characteristics are suggestive of secondary headaches. So look out for this. For example, what is a thunderclap headache? Thunderclap headache means that many of you or migraineurs will know that the moment, I keep talking about migraine because 99.99% of the time when you see a patient with a primary headache syndrome, it's going to be migraine. Okay, the other headache syndromes are rare. Okay, and sometimes overdiagnosed. Okay, so remember, migraine is common, terribly underdiagnosed and undermanaged in the community, probably because of its benign nature, but you need to know it well. Okay, and because it's a common disorder, it can manifest in many ways. Now, and if you are a migraine, you'll know that it never occurs suddenly like this, thunderclap. Okay, usually you'll wake up and say, oh my God, today is the day. You feel a bit odd, feel a bit nauseous, feel a bit photophobic, feel a bit lightheaded, feel a bit dizzy, you know. And then soon enough, you get this throbbing. Maybe sometimes you get some visual aura, like fortification spectra. You get what looks like a kaleidoscope that builds up, you know. And then soon after that, the headaches come. And the headaches will start usually very mild, one-sided, throbbing, boom, 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 boom. And then slowly it spreads. Before you know it, in a half an hour, 1 hour's time, you get a full-blown headache with a photophobia. Okay? Well, thunderclap headache means that at the onset, it's at maximum on. Okay? Now, that is usually characteristic of some kind of vascular phenomenon, like subarachnoid hemorrhage, cerebral venous thrombosis. These are the patients who come and tell you maximum at onset. Okay? So, thunderclap headache refers to secondary vascular pathology. So, look out for it. Okay? But often, I find that doctors mix up thunderclap headache with severe headache. Severe headache is not necessarily a red flag because migraineurs will tell you that the headaches are often very, very severe. In fact, most of the most severe headache patients I've seen are not secondary headaches, they are primary headaches. Migraineurs, cluster headaches, trigeminal neuralgias, these are some of the worst headaches that the patients can suffer. In fact, cluster headache patients have been known to commit suicide because of the severity of the headache. Okay, so severity of the headache or worse ever headache is not necessarily a red flag. So just be careful because many times patients, especially if they have a secondary gain or psychosomatic overlay, they'll come and tell you, oh, this is the worst ever headache. And then next month is the worst ever headache. Every headache is the worst ever headache. So not necessarily bad. I'm not saying it's, don't ignore it. But when they tell you it's a thunderclap headache, which means you need to ask them, at onset, is it out of 10 out of 10? If you ask them specifically, okay, don't just say was have a headache. At the beginning, often not easy. You have to tease this out from our patients. Okay, so they often will tell you, yeah, doctor, you're right. No, just listen carefully. Ask them again. At the beginning, is it maximum? Then it's vascular. Okay, and most of our primary headache syndromes don't start off at night. And you don't fall asleep, and then in the middle of the sleep it wakes you up. That's usually not a primary headache syndrome. Usually it's a secondary headache syndrome. Okay, then headaches that are persistent, progressive, goes on for many days without any relief. Of course, it can be primary headache syndrome, but more often than not, from an emergency setting point of view, you have to consider whether this is secondary headache, because most primary headaches, you will know, okay, even if you don't see a doctor, it will go away in 1 or 2 days' time. Okay, if it goes on forever and forever, persistent, unremitting headaches, usually they something for you to take note of. Okay, again, if I had a certain sort of headache, which is migraine, but now, because remember, migraineurs can also get meningitis. So if a migraine comes and tells you, doctor, I have a headache now, okay, but then tells you the headache is different because now it's generalized, there was no aura like I usually have. It didn't start off in slowly, and then didn't start off with a throbbing headache on one side. It just became generalized immediately. Then it's a different thing altogether. Okay, and similarly, because primary headache syndrome is constitutional, meaning it has a genetic factor, usually they start off in a young patient and they go on for a number of years, and then in older age they get a bit gentler and goes away. Okay, it may persist in older age, but hardly ever starts in elderly patients. So when you have new onset headaches in elderly patients, it's not likely to be a primary headache syndrome, because, as I said, primary headache syndromes, often there is a constitutional, that means there's some genetic environmental factor that starts off when you're very young already. Okay, so it shouldn't be something new. So when you see these things, you need to take notice. Okay, and the last thing is always remember to take the patient's comorbidities into context. Okay, so the first two set of information in one set of patient profile will have different connotation when put into the context of a different profile. So same headache profile, same set of red flags or whatever, in a young patient who's secretary, who's got no medical problems, comes to you well-dressed and everything, as opposed to a 70-year-old patient with diabetes, high blood pressure, maybe got HIV but didn't follow up with NCID, defaulted treatment, also has got ethanol abuse. The same set of first two information, but in this patient, you're going to react differently as opposed to a 22-year-old young lady who works as a secretary, who's got no other comorbidity. Simply because the second set of patient has got so many other comorbidities that are more likely to make the patient develop secondary cause for headaches. So therefore, always take the first two questions in the context of the patient profile. Patient profile meaning the patient's comorbidities. Okay, if the patient has no comorbidities, of course, can still be a secondary headache, but you're less likely to consider it. But if the patient is on immunosuppressants, is a diabetic, and all these things, then you're more likely to think about a secondary cause, right? So just like a person comes to you with sounds like a TIA, a stroke-like symptoms. Of course, if the person has got multiple comorbidities like smoking, diabetes, high blood pressure, hypercholesterolemia, sleep apnea, you're more likely to consider this to be a TIA, right? As opposed to somebody who's got no comorbidities at all, right? So the same way, the comorbidities will raise this Bayesian matrix in a way, will either raise the pretest probability or reduce the pretest probability of this being a primary headache versus a secondary headache. Okay, so after this three buckets of information, bucket 1, bucket 2, bucket 3, then you mix them up into the quadrant, and then you then decide, okay, are you going to treat this patient as a primary headache syndrome patient, or are you going to evaluate for a secondary headache? Okay, And then you have to ask yourself, what is the secondary headache that I'm suspicious of? Is it intracranial hemorrhage? Is it meningitis? Is it cerebrovenous thrombosis? Is it subarachnoid hemorrhage? Decide what is the underlying disease that I'm suspicious of as a secondary headache, and then decide, was it likely or unlikely? If it's very unlikely, then you could either do simple things like observe the patient or do a simple screening test. But on the other hand, if the pre-test property of this being a secondary headache is super high, then you realize that this patient requires admission for evaluation. Okay, and in terms of evaluation, you will choose a test with very high sensitivity and specificity. Because if the pre-test property is so high, then a screening test, for example, a plain CT scan, being normal, would not rule out meningitis, for example, would not rule out many other conditions that we talked about. So therefore, no point doing a simple screening test in persons with high pre-test property. This patient requires high specificity, high sensitivity sort of test. So might as well admit the patient for these tests. Okay, so that's how I evaluate it. Okay, so with that now, I'm going to go on and talk about some case history so that we can illustrate how we apply this. And it's much more useful to talk about cases that we didn't do so well, and then learn from those experiences rather than talk about cases that we got right. So let's deal with some of these cases and see what happens. Okay, so this is a real patient, a 21-year-old lady who came in, was admitted to emergency department, or rather came to emergency department for headache. And at a triage, her main complaint was 2 days of generalized headache. And she mentioned to the triage nurse that she has minor episodes like this before. She's 21 years old. Okay, so she was actually a real patient that we saw at the observation room. Me and my medical officer who have to come down and see patients, right? And we came down to see this patient. So this is the chief complaint that we saw. Okay, then we opened up the emergency department notes. Okay, and these were some of the things that were written in the emergency department notes. Okay, patient looks quite well, and then the clinical examination was quite unremarkable. She was given a course of analgesics, and then written there, let's observe. But after a course of analgesics did not make her better. Okay, then the decision was made to do a CT scan, and then the patient was, the CT scan came out normal, and then the patient was awaiting admission to neurology. So therefore, we went to see the patient. So while reading this, my medical officer or resident went ahead to get the cow, right? So that we can get more information and start locking the patient. So while reading this and while he was getting the cow, I went ahead and spoke to her very briefly and confirmed the initial impression from the emergency department that it's probably a young woman who's got a headaches in the past, now comes in again, feels otherwise quite well. Neurological examination is quite normal. She's afebrile, neck is supple, and it's probably migraine, right? So looks like migraine, sounds like migraine, smells like migraine. Like they say, if it walks like a duck, quacks like a duck, looks like a duck, and in our local context, even tastes like a duck. So it must be a duck, right? So I said, it's probably migraine, right? So let's go on to the next case. I was telling the resident. But the resident was very conscientious, opened the car, right? And he was looking through the notes. And then he says, Doctor, actually, there are some things that I must tell you from the past medical history. She's actually a patient with lupus since the age of 12 and complicated by lupus nephritis, difficult to control hypertension. She was on steroids and immunosuppressants. And at the age of about 18, she was transferred from KK Hospital to rheumatology department at Toxing. Remember, she's now 21, right? So for the last 3 years, the rheumatologist and the renal physician, Tan Toxing, have been struggling with lupus as well as nephritis. And then recently, her blood pressure has been very difficult to control, increasing her immunosuppressants and antihypertensions because it's been difficult to control both lupus, nephritis, as well as blood pressure. Okay, so once you give this information straight away, you realize that this and this two different set of information, right? Okay, same initial history, but suddenly the scenario changes, right? This is what I refer to in clinical medicine as the still point of the turning world moment. I think many of you would experience that in many, many contexts, right? In the emergency department, you often see this when you get your trauma patient, when everything moving around like crazy, and then right in the middle of in the eye of the storm, managing your trauma patient, right? So still point at the turning world, beautifully described by T.S. Eliot. So this is the moment that I had, okay? But more importantly, it illustrates a very important clinical bias, which we refer to as a framing bias. That means that we'll talk a little bit about metacognition in medicine, because many of you are either emergency department or internal medicine trainees, or general physicians, or primary medicine trainees, or even examiners. So we need to understand metacognition quite well, because for you to progress in medicine, which is basically how your brain thinks when you make clinical decision, clinical reasoning principles. One of the things that we often talk about is the framing bias. That means that how you would decide on a set of information is determined by how the data is framed. The same set of data, how is it framed? Remember, when it's framed this way, you make a certain decision. When it's framed this way, you make a different decision. So this is known as framing bias. So that means that you realize that if there is a bias like that, you need to be aware of it and realize that how you frame the clinical question will change how you make decision. So that's why we are particular in, and we already spoke about it, right? Headache, it's even more challenging than normal clinical problems in the sense that it can be a symptom as well as a disease. So very prone to all these biases, including framing bias. So therefore, you must use a formula. You cannot use gut feeling. This is gut feeling related. Gut feeling, gut feeling often fails you. And we'll talk about gut feeling in clinical medicine. So gut feeling is terribly overrated. It is this instinctive 2 + 2 = 4 sort of part of your brain. When you say 2 + 2 = 4, you don't need to think about it. Instinctively, you know the answer, right? So that's the part of the brain which is very important. We evolved that part of the brain for us to make instinctive decision. But in clinical medicine often gets us into trouble, because the part of the brain that requires that you need to engage is not the 2 + 2 part of the brain, but it's the formulaic part of the brain, okay? Which is basically systematically looking at the data in an unbiased way, okay? It doesn't take long, but it requires you to still do it, okay? So that you can be right by design rather than chance. And that's the formula we already introduced. So now let's really reframe the question now, okay? Using the 3 questions that I told you that we should use, rather than, see what I did just now, right? I instinctively made a decision that this is probably migraine, let's go on to the next patient, right? But there was probably, maybe right, maybe wrong. But let's try applying the same, for the same patient, reframing the question using these 3 questions, okay? So again, this set of information is not incorrect, no? It's the same set of information, but we have to reframe it on based on the 3 questions, okay? So it doesn't take long. First of all, headache profile, okay? The patient does confirm that she does have recurrent one-sided throbbing headache that spreads to the other side, since the start of menarche, okay, consistent with migraine. So that part is correct now. There's nothing nothing unusual about it, okay? So that part was correct. So yes, indeed, she does have a primary headache syndrome, okay? But red flags, what is important about the red flags is, it's not intuitive that you'll pick up all the red flags. You need to go through a checklist, right? And if you don't go through a checklist, just like a pilot, the pilots go through a checklist because they need to be correct 100% of the time. No point being right 99% of the time. You will still crash the plane, okay? So similarly, when you are a physician, you need to be right 100% of the time, because if you're right 99% of the time, now the 1% is still a person. So you need to, it's not an option for us not to use formula, so not to use a checklist. So here in this case, when we reapply the questions and using a framework of checklist, me and my resident, we went through with that. We said, Madam, do you have any symptoms of local focal neurological deficit, double vision, dysarthria dysphagia? We just go through the sets of information, the cranial nerves, double vision, weakness of the face, numbness of the face, dysarthria dysphagia, unsteadiness of gait, weakness of the one side of the body. And she confirms there was nothing. Okay. Then we asked, do you have any obtundation of sensorium? Which we didn't get early on, right? But she didn't really say no, nothing. But at this point, her mother, who was sitting by by the bedside or the trolley side. She immediately said, "Doctor, actually now that you mention it, the reason why we were alerted to a problem was because yesterday, we heard a sound in a bedroom. And we went into the bedroom and we saw her lying next to the bed, and she was drowsy at that time. Then when we went and woke up, she woke up and we asked her, why are you lying on the floor? She said, oh, I've got a bit of headache and I fainted. But it was a very transient faint. And then we didn't mention it early on because nobody had really asked this question. So something unusual, right? So why would somebody with headache suddenly lose consciousness at the onset of headache, right? So something for you to take note as a red flag. Okay. Then we went on to the third question, which is symptoms are raised pressure. She said no vomiting, no worsening on lying down, no worsening on coughing or straining. So nothing to suggest raised pressure. And then we went through the constitutional symptoms again. We asked her, do you have any body ache, fever, loss, anorexia? At that point, the mother again volunteered. Actually, yesterday when we took a temperature, she was 37.7. Remember, she's on immunosuppressants, right? We'll come to that in a minute. Yeah? But we already mentioned to you, right, that she's on immunosuppressant. So immunosuppressant patients, you'll be very lucky if they manifest features of sepsis, right? So if often they don't manifest the classic features of sepsis like temperature and all that. So you have to be careful, right? So here she did have a low-grade temperature the day before. Okay? Although now she's able. So again, red flag. Maybe because it's low-grade, you want to make it a pink flag. Okay, that's up to you. Okay. Then the characteristics of headache. On further questioning, she says yes, it is similar to the previous headache, except it is a bit worse and it's a bit unremitting. That's why I decided to come to emergency. Again, as I said, not thunderclap in nature, but severity, some change in character. So not quite sure whether it's a red flag. So we decided to put it as a pink flag. So you realize one definite red flag and two pink flags. Okay, something for us to take note of when we make a decision. Okay, so you realize that earlier on when we did unfocused sort of history taking, we didn't get much points, but when we go through a checklist, we realized that we were much more productive in pointing out symptoms that could have been missed. Okay, then finally, patient profile, and we already alluded to it, right? So she's got lupus, she's on immunosuppressants, steroids, and mycophenolate, and she's on 2 or 3 antihypertensive drugs because the nephritis is going out of control and blood pressure is out of control. So in this context, you realize that if you put these 3 sets of buckets of information down, you realize that, of course, it could still be a migraine that became worse. But then now you realize that you have to consider secondary headaches. Okay, because firstly, she had loss of consciousness, she had low-grade temperature, and low-grade temperature is important in the context of immunosuppressants. Okay, and she also had a change in character. And this is not an average. If she was an average 21-year-old patient with nothing else going on, this can easily be a migraine exacerbation. You can treat the patient and discharge the patient. But obviously, this patient has got all these medical problems, so therefore you need to evaluate it further. But how would you evaluate? That's the next point. Okay, how would you evaluate? Well, there are 2 points that you need to consider. Okay, now from your emergency department point of view, once you've decided you need to evaluate further, then I would suggest that the important thing is just to admit the patient, right? Okay, I find that a lot of times when you order investigations like scans and all these things, it just delays things. The nurses in the observation room, Ama, and all these people will tell you a lot of work for us, you know. So bringing the patient here and there and everything. So important thing is for you to just admit the patient. Of course, if it's if there's a delay in the patient going up the ward and treatment, of course you need to give the patient treatment based on your index suspicion for the primary headache, right? Index suspicion for the secondary headache, sorry, right? But how would we, when we see this patient, how would we evaluate this patient? Firstly, we ask ourselves, what is the likely secondary headache in this case, if it's not a primary headache? Since there is some red flags and comorbidities suggest that it could be a secondary headache, we want to ask ourselves, what are the likely conditions that could present like this, number 1. Number 2 is, what each of these conditions that we are suspicious, what is the pre-test probability? Are we very suspicious, moderately suspicious, or minimally suspicious? Based on that, then we choose the investigation. So this is something that for medical students, often we don't talk about, but for you guys as practitioners now, whether you are a MOPEX MO, or whether you are a trainee, or whether you are an ED doctor or a physician, you need to know this. Okay, this is important principle. Always when we do tests, the test that we choose is determined by, okay, the pre-test probability. Whether you do a stool local blood or whether you do a colonoscopy, depends on what is your pre-test probability of this patient having carcinoma of the colon in front of you. Okay, in the community, the pre-test probability is low, you do stool local blood. But when somebody comes to your surgical ward with loss of weight, constipation, tenesmus, blood in the stools, the pre-test probability is so high, you wouldn't waste time with stool local blood, you'll arrange a colonoscopy, right? So these are some of the principles that you must understand that is kind of universal in clinical medicine. Okay, and of course we apply it in ethics also. Okay, so let's see what we did for this patient. We thought about some condition. Okay, because of a hypertension being out of control, there is a form of hypertensive encephalopathy called PRES, which is posterior reversible encephalopathy syndrome. Okay, simplistically saying, it is basically hypertensive encephalopathy. Okay, due to severe hypertension, usually in context of secondary hypertension, patients with kidney disease, autoimmune disease. We're not talking about chronic elderly patients with severe hypertension who comes to you and because they have pain somewhere and then the blood pressure goes up. No, that's not what we are referring to. The PRES is a specific condition. Okay, it's characterized by, it's very analogous to what patients in pregnancy, when they have pregnancy-induced hypertension, they get eclampsia. It's very similar to that. Okay? So the index suspicion for PRES was quite high because in lupus nephritis, as well as systemic lupus erythematosus, they are procoagulant. So this could easily be a cerebral venous thrombosis. So these were all, that's why I put it in big font, these were all considered to be highly likely. Now, because she had low-grade fever, meningitis was possible. Okay, but currently there were no features of meningism. So we didn't think it was super high, but because she's on immunosuppressant, some of the features of sepsis may be masked. So we couldn't exclude it, but we put it as something of moderate possibility. Now, other conditions like subarachnoid hemorrhage, intracranial bleed, we thought it's still possible, but very low. Why? Because she had no focal deficits, wasn't thunderclap in nature, and the plain CT scan was normal, right? So therefore, we put it as very, very low in probability. So these conditions on the top part of the curve are very high probability. Those on the bottom part is low probability. Okay, so if it's very high probability, then as the CT scan being normal does not rule that out. So no point you waste your time with the CT scan. That's why I said sometimes you decide you're going to admit the patient, don't waste time, just admit the patient, right? Because the test that you need may require some deliberation and require some planning and all these things. So might as well get them in the ward and then get them admitted if there is time for you to. Of course, if it's emergency, you will do it immediately. But in this case, what the patient requires is an MRI and MRV because the pre-test probability of PRES and CVT is super high. Okay, in the next condition, meningitis, the pre-test probability is not so high. So I wouldn't want to LP the patient immediately because the pre-test probability is not so high. So what I will do is I'll screen the patient with inflammatory markers like ESR, CRP, and Procal and things like that, right? Now, if let's say this lady had very high fever, neck stiffness, I wouldn't even, I mean, of course, I'll do the test, but I wouldn't really worry so much about the ESR, CRP and all that. Because whatever the test shows, the pre-test probability is super high. I would cover her for meningitis and I'll arrange a spinal tap, right? So that's how the decision-making process is made, okay? So with this test, we went ahead, we did this test, and because the screening test was high, CRP Procal came up still quite high. ESR was very high. In this particular case, whenever you do a screening test, if the screening test comes out high, let's say a stool local blood is high, in the context that we talked about, we won't ignore it, right? We bring the patient from the community and evaluate it. So in this case, the screening test was high. So we quickly started antibiotics, arranged for the MRI, MRV. We said, okay, let's wait for the MRI, MRV, start the antibiotics, high dose meningitic doses of antibiotics. And then we get the patient in the ward, and then subsequently we'll LP the patient. But let's do the MRI and rule out these two first. Okay. And then later in the night, MRI was done, and my resident calls me, my senior resident calls me, registrar calls me and says, actually, the MRI is abnormal, but not in the conditions that we suspicious. of, in fact, with one condition that we didn't consider, I should have considered but didn't consider, was vasculitis. As you can see here, she has got multiple infarcts in the brain. Lupus is associated with CNS as well as systemic vasculitis. And that's why her lupus nephritis was getting worse. So she had systemic vasculitis that was previously not diagnosed yet. But with this changes in the MRI and MRA, you can see in the MRA, there's some bleeding in the blood vessels suggestive of vasculitis, and then the infarcts in the brain. But there was no signs of cerebral venous thrombosis or PRES. So with this, the patient was pulsed with high-dose steroids and cyclophosphamide immediately. Well, we started steroids in the middle of the night, but the next morning, the rheumatologist started cyclophosphamide. And so that's how this case went up. Okay, so you realize that the formula is, although it's not complicated in the sense that it doesn't take too long, but allows you to systematically solve this problem rather than use instinctive feelings, which sometimes can give you the wrong answers. Okay, and this was a classic example. And let's think about where I went wrong when I first saw the patient. I thought, okay, this is probably migraine. First of all was the framing bias, right? Because I framed it based on only on the set of information that was available there. They didn't bring in the comorbidities, which is the third set of questions in your 3-question approach. Okay. Then there's something called anchoring bias. The anchoring bias means that once you the first set of information you get, and then you quickly make a decision, and then you prematurely close the diagnosis. After that, you don't want to reconsider anything else. Premature closure of diagnosis is called anchoring bias. And then finally, there's a confirmation bias. It's kind of overlapping with anchoring bias, because once you have decided that it's migraine, then you're only going to collect information that's consistent with migraine. You're not going to consider anything else. You close the diagnosis. So these were the 3 sets of biases that were already there when I initially saw the patient and misdiagnosed the patient, right? The other errors here is, of course, you notice that when the patient was seen in emergency, a CT scan was ordered, because there is this preconception that even CT scan, even MRI, okay, that a neuroimaging conquers all headache syndromes. You realize that my MRI is normal in meningitis patients. MRI will be normal in temporal arteritis patients. MRI CT scan can often be normal in many of these conditions, including subarachnoid hemorrhage, presents late. So therefore, don't think that neuroimaging conquers all. That's a common fallacy among many of us. Okay, emergency department, general physicians, neurologists, all of us. Okay. Then there's also a fallacy of therapeutic trial. You notice in this case, the patient was given some analgesic, and then subsequently was re-evaluated, and then patient's headache is not getting better, and therefore let's re-evaluate. That's again a fallacy, because if you think about it, the fact that the patient has responded to analgesic doesn't mean anything, right? Because just like acute abdomen, right? The fact that the patient responded to analgesics would not change your mind about acute abdomen. In fact, you would make a diagnosis of what the cause of the abdominal pain is first before you consider any analgesics, right? So you wouldn't want to mask the pain and all these things. So the same way, the fact that the patient's pain got better doesn't mean anything. Patient's pain can get better because the patient's with meningitis, for example, give a bit of analgesic, the patient may transiently feel better. But on the other hand, migraine patients, your analgesics may not be effective enough, and the patient's pain may not get better in status migrainosus. So the fact that the patient's pain get better or not better is not really an important thing. So I often tell emergency doctors, don't waste time with this therapeutic trial. If you think, apply the 3-question formula. If the patient, if you think that this is a secondary headache, requires evaluation, just admit the patient. Okay? So don't waste time with this analgesics. And then you just clog up your observation room. Because in my opinion, a trial of analgesic has got a very small role only. Okay? Now, then another area of error which we have talked about, which we'll talk about later in more detail when we talk about dizziness, is this gut feeling sort of thing, which is terribly overrated in internal medicine or the whole of medicine, where you look at a patient and then you make a judgment. Okay, this is the so-called 2+2 part of the brain, the instinctive part of the brain. When I tell you what's 2+2, even without any energy, you didn't use up any ATP, you didn't use up any glucose, He didn't use up any powers, you know, just said 4. It's involuntary. So the involuntary part of the brain, it's active all the time. So it's intrusive. Okay, it's very important for you to make decisions like when you're driving, red light, you stop, right? On the other time, on the other hand, if you want to make a route to an unknown area, you want to chart out a route, you cannot use the instinctive sort of thing. Or it looks like probably I have to turn left. It looks like this is south, this is north. Then you're going to get in trouble. You need a plan, right? And that's when you need to use other parts of the brain. So if I were to give you, later on, I'll give you an example. If I were to give you a mathematical problem like 245 times 456, obviously you cannot use your instinctive part of the brain. Right? You need a formula. So headache is a complex problem. So we don't use a formula, we use the instinctive part of the brain. Patient looks well, he's a young patient, he's walking around, you know, the kind of all these words that we use don't mean much on their own. Okay. And so don't rely on gut feeling, use formulas. Okay. Now I'll use another case to quickly illustrate this. Okay. Again, I use an example of a patient that I misdiagnosed. Again, because I used the instinctive part of the brain, didn't use, because as I said, instinctive part of the brain doesn't need any energy. Just, you know, your lazy part of your brain. So for you to use this, you need to consciously shut it off and use. So it requires energy. It's kind of painful. It feels the ache. No, not headache, but you know, the tiredness. So therefore, your brain won't want to use it. So you have to consciously use it. So this is a patient that I was seeing for a lot of non-specific complaints for a number of years. Okay, non-specific, most likely functional neurological disorder. Okay, and he was also seeing other doctors like irritable bowel syndrome, other doctors for many other non-specific functional disorder. Okay, he gets admitted to the hospital for headache this time. Okay, through the emergency department, and the ward doctors call me and say, "Hey, doctor, your patient is admitted now for headache." Then the moment I recognize his name, I say, "Oh no," you know. Straight away, I said, made this anchoring bias was this patient must have a primary headache syndrome, and the big face on the fact that he's got a and a confirmation bias because he had previously psychosomatic symptoms. I only wanted to get information that confirms my bias, because immediately the houseman told me that, you know, he reported that recently he was getting divorced and the divorce lawyer was giving him a hard time. It's not a very good lawyer, so he was very unhappy with this, with the divorce as well as the lawyer. So he was very stressed out. So I only got that bit of information. Didn't get any other information. I only got information to confirm my initial impression, the psychosomatic. So I told them. Then I asked them, what else was done? Or a CT scan was done. So again, the same fallacy. The CT scan counters all. So CT scan is normal, and clinical examination was normal. So I told the neurology medical officer and said, hey, nothing specific lines. Probably it's non-specific migraine sort of tension headache sort of primary headache syndrome. So please treat him and symptomatically and discharge him and give him my usual follow-up. That's what I said. But luckily, this was a patient in the ward, right? So there's a ward consultant. So one of my colleagues, Dr. Adeline, I think you may have worked with her before. She's one of our best neurologists. So luckily, she was the ward consultant. So she, of course, was well trained. And I like to say that she was trained by me, but then unfortunately, she was trained also by other people. Sorry, I shouldn't say unfortunately. She was also she was trained well by a lot of people, and therefore didn't really rely on my information alone, and decided to apply the 3-question formula that I've spoken to her many times before. She said, "Hey, actually, why don't we just apply the 3-question formula rather than just make a diagnosis, right?" So she came around and found out actually, in spite of his psychosomatic nature, the patient never had a primary headache in the past. Never ever, you know. So never was seen or treated for headaches in the past. So he doesn't have a primary headache. So 65-year-old man suddenly coming with headache, of course, can be a new onset headache, but you know, it's a bit odd, right? Yeah. So the first set of information was that there was no primary headache syndrome. Okay. Then the next thing was red flags, and again, I didn't go through the checklist, right? she decided to systematically go through the checklist, okay, and discovered that actually he had no obtundation of sensoria. He had no symptoms of raised pressure like vomiting and all that. He had no constitutional symptoms like fever, anything. But he had some diplopia onset of this headache. So there was something that the checklist revealed, that my initial non-checklist based dismissal of his complaint did not reveal. So when the ward consultant went through the checklist, she found out that actually there was a red flag, which is the patient had diplopia this time, or rather this, because remember he never had headaches in the past, right? So he had diplopia at onset of this headache. Okay. Then the characteristic of the headache was persistent, okay, and non-remitting for the last 1 week, which is also unusual for primary headache syndrome. So, so she wanted to consider that as a primary headache, as a secondary headache red flag also. So she had 2 red flags. She picked up 2 red flags, which I didn't pick up simply because I didn't use the active part of the brain to actually go through the checklist, right? Just use gut feeling. Then the patient profile was important. Remember, I knew this patient from before. So I assumed that I knew everything about the patient. But actually, between my follow-ups, he was recently admitted, between this admission and my follow-up, he was admitted to another hospital, Kutipwa Hospital, for his TIA-like symptom. And at that time, they did an ultrasound of his carotid and found he's a 65-year-old Asian man. It's very unusual to have bilateral carotid disease. He had bilateral carotid disease. And because of bilateral carotid disease, he was given an appointment with the neurosurgeons. Come back to neurosurgeons in Manila for consideration for surgery, because he had a bilateral carotid disease with transient ischemic attack. This is something important in the patient profile that I didn't elicit because of the 2 biases that I already have, framing bias and confirmation bias. Only looking for information like the divorce proceedings rather than asking the medical officer, was there anything else in the patient profile that I should know about? Okay, this one, what Dr. Adeline elicited. So with this 3 sets of information, firstly, no primary headache profile, no primary headache syndrome in the past. Number 2, 2 possible red flags picked up on the checklist for red flags. And 3, patient's comorbidities suggest that he's got some kind of vascular pathology. So with that, but the patient's clinical exam was still very unremarkable. He looked very well. She was telling me that patient looks very well. But nevertheless, with this, she called me. She called me, being a very conscientious doctor. She called me and said, Dr. Umar, I think the patient that you thought we can just discharge, but I'm a little bit nervous because he's got, I agree, he looks well, but he's got 2 red flags. I think we have to consider the possibility of secondary headache syndrome. But I agree, the pretest probability is not super high, but I still think that there is a moderate possibility of giant cell arteritis because he's got vessel abnormalities unusual in Asian men, 2 bilateral carotid disease. Okay, so although it's not, although the pretest probability is not high because it doesn't have polymyalgia rheumatica and all the other symptoms of giant cell arteritis, he doesn't have jaw claudication, all the other symptoms. But nevertheless, because pretest probability is high, shall we do an ESR? Okay, and I say, of course, please do. And true enough, ESR came back very high. We proceeded on to do an ultrasound temporal arteries, and it was very abnormal. Went ahead with specific investigations and confirmed that this patient had giant cell arteritis. Okay, so in the past, of course, he had many other psychosomatic complaints, but this time it was giant cell arteritis. And what are the biases here? Firstly, the patient doesn't have a primary headache syndrome. Of course, he could have developed a primary headache syndrome at 66 years of age, could have, but it's not something that you should just assume. Okay. Then the red flags, if I had screened conscientiously the remember 5 questions were asked. Okay, then I would have picked up that there were 2 red flags, which of course Dr. Adeline was well trained, as I mentioned, not well trained by many people, and therefore she knew to apply things conscientiously and diagnosed 2 red flags, and therefore raised the index of suspicion for possible condition. And then, of course, the patient profile was important in this context. I was only focusing on the psychosomatic factors, but she picked up this history of recent TIA with bilateral carotid disease. Okay, so again, anchoring bias, confirmation bias. Okay, you can see obviously these were two dark forces that were influencing me to make the wrong diagnosis. Okay, okay. Then of course, the importance of checklists. I already alluded to it. If you the checklist is something that's very, very crucial for every part of medicine. So whether you are seeing a patient with anemia, a patient with bleeding GIT, if you have a set of checklists to consider before you dismiss this as that you have sent the patient away from your care because you've done what's needed, then you're less likely to miss out things, because you have a set number of things to satisfy before you release the patient. The same reason why a pilot, you talk to your friends who are pilots, they will tell you that no matter how senior they are, the airport will never release, allow them to fly the plane on unless they submit a checklist, because they want to be correct 100% of the time. Okay, so seniority, experience, all this doesn't matter, because for safety, you need a checklist. So same thing for clinical medicine. Diagnostic acumen translates to safety for the patient. So therefore, you need to apply checklist. Okay. Okay. So this is what we talked about. So CT scan normal again. In this case, CT scan normal doesn't mean anything at all. Right? Even MRI would have been normal for a patient like that. What you need is an ultrasound of the temporal artery. That would have been determined by the pretest probability. So that's why I say that in ED setting, a lot of times you have this false sense of security when you all image the patient. Don't. So you need to decide what kind of test is most useful for the patient. Okay. So I'm more or less done for headache. So I want to go through, as I said before, most of you are postgraduate students. So therefore, in fact, all of you are postgraduate students. Some medical students may be listening in, but still, postgraduate students, it's important for you to understand metacognition, or otherwise known as clinical reasoning. So we already talked about it. We said that because headache is a complex clinical problem, you cannot use intuition. If you use intuition, error rate is high, right? So therefore, for you to be correct all the time, error rate high means somebody is going to be harmed. Patient is going to be harmed, right? So therefore, it's not really a choice that we have to use a formula. Okay, and the formula need not be too tardy or too long-winded. It just allows you to accurately make the diagnosis and less likely to fall into biases. Okay, and we talked about the three-question approach. Understand what is the pre-morbid headache syndrome. Does he have a primary headache syndrome, he or she? What are the 5 red flags to go through? Okay, and then what are the patient comorbidities, and does it increase or reduce the probability of this patient having a primary headache syndrome or a secondary headache syndrome? Okay, and based on your index of suspicion, you will decide what test you will do. Okay, so this is some of you are mathematically very astute. You know that the way the patient profile affects the first 2 questions is Bayesian in nature. In Bayesian matrix, we learned it in mathematics, right? Yeah. So it's not a linear equation; it's Bayesian. So that's we talk about very esoteric terms like clinical judgment, clinical acumen, but actually there's mathematical principles behind it. So as you are training, if you learn underlying principles, the undercurrents, it's easier for you to swim in this ocean of clinical medicine. Okay. Now, remember I said that after you formulate a list of possible secondary causes, if you think that this patient's problem is not primary headache, it's possibly secondary headache, then you ask yourself, what are the possible differential diagnoses? Is it subarachnoid hemorrhage, intracranial hemorrhage, meningitis, cerebral venous thrombosis? Is it what other conditions causing headaches in the emergency department? Trauma-related intracranial hemorrhage. So you decide what is the pretest probability of one of these conditions presenting a headache in this patient. Okay, then you choose the test. Okay, that depending on your pretest probability. Okay, if the pretest probability is super high, young patient, elderly patient with dementia, falls, we're talking about trauma, right? Subsequently comes to you for headache, Pre-test probably subdural is super hard. So you cannot send the patient home with injury advice. You need a plain CT scan at least, okay, to rule out subarachnoid, subdural, a chronic subdural, or an acute or chronic subdural. Okay. Okay. On the other hand, if you see a young rugby player concussed on the field, comes to you, pre-test probably of this being intracranial hemorrhage, traumatic hemorrhage is low. Perhaps if your clinical examination is normal, you want to discharge the patient with headache advice is reasonable because the pre-test probability of this being traumatic intracranial hemorrhage is low, right? So you realize that you're already doing it, but I'm just trying to articulate the principles so that you know what are the streams, undercurrents behind your clinical reasoning, so that you can jump onto it and facilitate this journey. It's just like swimming in the oceans. Once you know where the currents are, it's much easier. Okay. Neuroimaging does not conquer all things. That's a big problem in all of medicine. Okay, not just in emergency department. A lot of us neurologists also have this bias that we think that once you reach the patient, you've covered everything. Okay, so as you know, meningitis, subarachnoid hemorrhages, and a lot of sometimes, patients who come in with subarachnoid hemorrhage, 24 hours later, the CT scan can be normal. It's the spinal tap xanthochromia that tells you that this patient had a subarachnoid hemorrhage more than 24 hours ago. So these are things that you must understand and take into account when you interpret or order investigations. Okay, fallacy of trial treatment, we already talked about. Okay, now once you've diagnosed this patient has got status migrainosus and you want to treat the patient, yes, it's important to treat. You don't want the patient to suffer. But if you haven't diagnosed what is the cause and you just want to give analgesics, and then if the patient's headache gets better, and then actually to me doesn't mean anything. So highly not recommended as a diagnostic tool. Of course, you want to do it as part of alleviating the patient's suffering, yes, but don't use it as a diagnostic tool. Okay. Then I mentioned to you earlier as the anchoring bias about psychosomatic factors. So psychosomatic factors should not come into your diagnostic algorithm. Often it gets you into trouble. What you need to do is, after you've made a diagnosis of a condition that is often associated with psychosomatic factors, like for example, if you in gastroenterology, if you make a diagnosis of irritable bowel syndrome, you know it's almost associated with psychosomatic factors. So patient's symptoms will never get better if you don't address the underlying depression, anxiety, and all these things. But just because the patient is stressed, just because the patient is anxious, doesn't make it irritable bowel syndrome. Because anybody with, if you go and talk to any patient with inflammatory bowel disease, they'll tell you they're super stressed because it's terrible to work when you have chronic diarrhea, you have abdominal pain. How are you going to function as a doctor or a nurse or a teacher and all these things, right? So you'll be super stressed. So just because it's stress doesn't mean that it's not a serious condition. So be careful about that. And then this is important point, not directly related to diagnosis, but I noticed there is a growing tendency in emergency department to use opioids. Please don't use opioids in the emergency department for headaches. Please don't use it. Okay, I can't think of any headache syndrome where you need to use opioids. Okay, if you continue using this when you approach my age, you will be dealing with a lot of patients with opioid addiction, like the Americans are dealing with now. There's a major opioid crisis in America because of the overuse of opioids. Okay, there's really no use in using any form of opioids, in headache syndromes. There are a few exceptions, but you can leave the exceptions to the person who's managing it long term. For example, in trigeminal neuralgia, okay, we often use opioids acutely when the patient is in a lot of neuralgic pain, right? But chronically, the patient requires long-term treatment like carbamazepine or gabapentin, drugs like that, right? So, but I noticed that very troubling. I see patients getting IM morphines and opioids in emergency department. I've worked in the United States before. It's a nightmare now. Okay, patients come very aggressive. They get into a lot of problems because they have been given opioids in the past and they become addicted. Okay, so don't use opioids for any of the conditions that we talked about. leave it to the primary doctors to sort it out. Okay, so this is the summary. I'm going to stop here for questions for about 5 minutes. If there are questions, I'm not going to look at the chat, so just it's difficult for me to negotiate on this. What you need to do is just quickly unmute yourself and ask questions.
Hi, Prof. This is Anjarat here.
Yes,
Yeah, sorry. Can I just ask a question about trigeminal neuralgia? Do you have any good recommendations or suggestions on what can we do for patients with very bad attacks of trigeminal neuralgia? They're not responding to the usual medications. Like what other additional stuff can we do in the ED that might actually potentially help the patient to avoid admission if possible?
Yeah, so number one, don't admit patients trigeminal neuralgia. No need, because these patients' pain is chronic. Okay, but they are in a lot of pain, right? So as I said before, there's a small area of in clinical medicine, in headache medicine, that we use opioids acutely. Okay, and that's in neuralgic pain like trigeminal neuralgia or zoster-related neuralgia. Okay, where we acutely, while the chronic medications kick in, use opioids. Okay, so in those contexts, you can start opioids. But you start the patient opioids and get the patient to come back 1 or 2 days time to see the neurologist. Okay, but these patients must see the neurologist. Almost always it's because the primary neurologist, the primary physician, the general practitioner is not giving the patient adequate prophylactic medicines. It's not an adequate carbapenem, trigeminal, carbamazepine. All these drugs is like anticonvulsants, right? Sorry, for seizures, right? The patient comes in for breakthrough seizure. Yes, you control the seizures now. But if the patient is not on proper seizure medication, it's going to come in recurrently for seizures, right? So the same thing for trigeminal neuralgia. So many of these patients, if you take a history carefully, they become a bit careless with their chronic medication. They think they can come off it. They come off it and then they will come to emergency for acute pain. So you can start the patient on opioids. Tell the patient, no matter how severe the pain is, it is not a life or limb-threatening condition. Admitting the patient in our current context where the hospital is overloaded, okay? Well, because what we do is we discharge the patient the next day. We discharge the patient the next day because we will just start the patient exactly on oral opioids. Tell the patient the opioids will kick in the next 1 to 2 days, but the long-term control of the pain will be over a period of 2 to 3 weeks, sort of thing. Okay, and you all know that you have the accessibility emergency department has the privilege of sending the patients next day TCU or 1 or 2 days TCU at the triage clinic, which is the neurologic clinic that sees patients immediately, right, the next day or the following day. So these patients can be sent in. Okay, so that's if the patient is admitted, that's what we'll do. We'll start the patients on either codeine or tramadol round the clock for 1 day or 2 days. Okay, until the patient takes the patient. Often the patient would have defaulted on the chronic medication, so we reinstate that medication and wait for those to kick in. So in your acute setting, there's very little you can do from emergency department. So you just start the patient with opioids, reassure the patient, and then discharge the patient to their primary doctor, because most of them come to you with a diagnosis of trigeminal neuralgia. Right? So that's what I'm assuming.
Okay, thank you, Prof. Thanks.
Sure.
Hello, Prof. I am Yin Tong from Emergency Department. I have a question regarding nausea and vomiting in headache. So, I mean, is there any very good particular question that we can use to ask to differentiate between like the nausea and vomiting in migraine and like when it might be something serious like a ICH, raised intracranial pressure?
Yeah, thanks for asking that question, because I kind of alluded to that earlier, but I didn't explain. So you see, notice that we don't rely on only one particular bit of information. Actually, it's a kind of a helicopter holistic sort of overview of the whole thing, right? So if a person comes to you with a chronic history of migraine, recurrent episodes, and often associate nausea, vomiting, and then the migraines will tell you that sometimes they need to gag themselves, right, to vomit, and then when they vomit, they feel better, correct? And so now they come to you, and then they're having a migraine attack, headache attack, and then they're vomiting. Now, the chance of you reacting to this as a sign of raised pressure is going to be very low, right? As opposed to somebody who has got no headaches at all, comes to you and is having headache and vomiting in front of you. Okay, so I'm giving you two extreme examples, polar examples, so that we know that, in one case it's clearly nothing to worry about, in the other case, clearly something to worry about, right? Of course, in clinical medicine, there'll be a lot of gray zones in between. So basically, if you use the 3-question approach, if the patient has got a primary headache syndrome consistent with vomiting, for example, migraine is often associated with vomiting, okay, which got no other red flags, okay, and the patient in the past also, every time there's a headache, she has nausea, she has vomiting, often needs to gag herself, but this time the headache is so severe, okay, so, and that's why she's vomiting many times, okay, and then patient profile is otherwise benign. So you, at the end of your 3 sets of questions, you're not just interpreting the vomiting, right? Using all the 3 sets of questions, you realize, well, this is likely to be a migraine exacerbation. There's nothing in my evaluation to suggest a secondary cause. The pretest probability of secondary cause is super low. So I'm going to treat it as for status migrainosis. Okay, remember the 3-question approach, and then he said treat for status migrainosis. And status migrainosis is a common problem in clinical, in emergency department. So that's why in your notes, I've given you some of the protocols. Okay, you need to treat them properly. First thing, observation room is not the best place for status migrainosis treatment because of the bright lights, the loud noises, the movements. Okay, these 3 things patients don't tolerate well: the trolley movements, the loud noise, the bright lights. Okay, they need to be sitting in a dark room. IV hydration and round the clock metoclopramide. Okay, that is the best treatment for status migrainosis. Within a day, it resolves. Okay, so that's what I would suggest. I think equally effective and often used in emergency department is a dose of IM ketoprofen. Okay, I think that's not reasonable. Most of the time in our ward setting, we neurologists, we don't like to use that because one of the big problems, we didn't talk about it here, one of the big problems when we manage headache patients is analgesic overuse, both by the physician managing the patient as well as the patient. So if you want to model behavior, if you use analgesic also, often the patient goes in thinking, oh, I'm okay to use analgesics. We want to prove to them that the best way to manage your primary headache syndrome long term is to concentrate on prophylactics. Just like your best way to manage asthmatics is not your nebulizer, which is very dramatic, right? But the best way is your prophylactic steroids, right? Your inhaled steroids. So the same way we want to illustrate it. So the answer to your question is not straightforward. It's not going to be a unidimensional view of your headache, but it's a multidimensional, holistic view of the patient's vomiting in the context of everything else. Okay, I hope I know it may sound like a cop-out, but that's really how we assess the patient's vomiting.
Okay, thank you, Prof.
Okay, so if there are no other questions, we'll go to the second part of the lecture. Since it's a virtual lecture, you can, of course, walk away and get your drinks or whatever you need to refresh yourself. So, you all can see my screen, right? Okay, so so we're going to talk about headache, and we're talking about dizziness, the second topic today. So again, I kind of alluded to it already, right? But I'm going to explain a bit more. So the 2+2, so when you see dizzy patients or headache patients, instinctively you come up with some gut feeling diagnosis. A lot of times it's incorrect. A lot of times it's incorrect, but it's the involuntary part of the brain. Okay, but what you really need to do is engage your voluntary part of the brain is the 2+2. The involuntary part of the brain. What you need to do is the voluntary part of the brain, where you really need to put in effort to solve this problem step by step. Okay, in this case, if you put in 245 times 435. You know the formula. Do one step at a time. Each step is easy to do. Okay. At the end of it, you get the answer. So a lot of clinical medicine requires this deliberate thinking. And some of you are interested in this topic. Actually, there's quite a lot of literature on this, and not just in medicine, but in other areas also. System 1 thinking and system 2 thinking. Okay. So most of clinical medicine requires system 2 thinking. Okay. But system 1 thinking intrudes into you and causes a lot of the errors. So system 2 thinking means you need a formula. So just now we talked about 4-question formula, right? And because dizziness is another terrible thing that frightens all of us, it requires a formula also. Okay. And it requires for headache, it's a 3-question formula. For dizziness, it's a 4-question formula. 4-question formula. Okay. So it also allows you to live longer because it reduces stress. As you know, dizziness is not something that all of us, universally, all physicians around the world, this has been studied. The number 1 symptom that most physicians hate to see is dizziness all over the world. Okay, no matter what language, culture, race, religion, you go to, the physicians will tell you they hate dizziness. Okay, so what are the 4 questions? First question is always ask yourself: is the dizziness likely to be a problem related to the vestibular system or central connections, or is it related to some sort of hyperperfusion of the brain? Okay. So the first set of questions, the first answer, the first bullet point refers to transient hyperperfusion of the brain. For some reason, the brain is not getting enough oxygen for a few seconds, and then you feel a bit faintish, a bit of syncope. That is the syncopal sort of dizziness that patients feel. Okay, as opposed to vestibular or its central connections, where the problem is, where the symptom is defined as vertigo. But what's vertigo is a technical term, right? So if you want to define it, vertigo is actually a illusion of movement, essentially, because the vestibular system controls or modulates the sense of balance when you are steady or when you're moving. So when it's abnormal, it's going to give you a sensation of movement. Often it is a rotatory feeling. But it can be a sensation of tilt to left or right. Okay, but often it's rotatory. Okay, so if you ask the patient, the sensorium is very much intact. I'm not feeling drowsy. I'm not feeling lightheaded. I'm not going to feel like I'm going to faint. But there are things moving around me when I'm not moving. That is vertigo. Okay. Now, that's easy for you and I to think about in technical terms, right? But how do we translate this to a question in history? It's a nightmare. Okay. Patients will tell you anything they want. Tau him, tau gong gong, tau boo boo. You know, all kind of funny complaints they complain. Like it feels empty, you know. But you need to reinterpret what they're saying into either one of these two. Okay, which is it a sensation of near faint? Okay, that means transiently. You're not losing balance, you're not having rotation of movements. You are transiently going to lose consciousness. You may overtly go on and lose consciousness, but it's a transient obscuration of senses, obscuration of your sensorium. Okay, as opposed to vertigo, which is a illusion of movement, right? So these are two polar symptoms actually, but the way patients describe it often is mixed up. Because, you know, when you are losing consciousness, sometimes there is you're going to fall, right? And you're falling, there's a sensation of movement. So they will tell you, oh, doctor, it's giddiness. On the other hand, vertigo patients, sometimes the spinning is not so prominent. So they will tell you, oh, I'm going to faint. But actually, it's a sensation of movement, sensation of imbalance. You're going to fall. And during the time, they're vomiting a lot. So this is the point that I want to, this is a tip that I want to give to you. If a person says he's giddy and is vomiting or feeling very nauseous, it's very likely to be vertigo. Okay, a sensation of near faint or syncope shouldn't have vomiting or nausea feeling. It's very rare. Okay, but vertigo patients, almost always there is either a sensation of nausea or vomiting. Okay. Now, if you look back at your own life experience, many of us experience vertigo physiologically. Okay, so you may have stood still as a child, for example. Often you play games when you run around somewhere, and then you stop, and then you feel things moving around you. That's vertigo, physiological vertigo. When you get onto your treadmill, you run on your treadmill, and then you get off the treadmill, a few moments you feel yourself moving. That's physiological vertigo. In the boat on in an ocean, the waves are very high. Then you get motion sickness. You want to vomit, seasickness. You want to vomit all over the place. You often don't tell people when they say, "Hey, how are you feeling in the boat?" Somebody calls you. You won't say, "I'm feeling vertigo." You'll say, "I'm feeling seasick." But actually, if you think about it, it's overstimulation of your vestibular symptoms, vestibular system. It's actually a form of vertigo. And that's why you're vomiting and nauseous all the time. So one of the questions I ask patients who can't really describe their dizziness, I often ask, do you feel like you're seasick or car sick? Okay? That kind of helps you. Again, the nausea and vomiting is very prominent in car sickness and seasickness, right? So therefore, that's an important tip. Okay, so the first question is important to decide, to discern. If you get the first question wrong, then subsequently the remaining 3 questions get ready. Okay, so do focus on the first question and try to delineate whether it's a vertigo or a non-vertiginous, syncopal, near faint sort of thing. Okay, now you notice that I don't use the word non-vertiginous symptoms here because it's a negative thing. The negative thing doesn't help you very much. So it's better to think of it as a near faint or syncopal dizziness, which is what often people use the word non-vertiginous dizziness. Better to think of it as, is it a syncopal near faint dizziness or is it vertigo? Vertigo is spinning with vomiting. Okay. Now, second question is, if the person does have vertigo, okay, then you will want to know whether the problem with vertigo, as I said, it's due to vestibular system in his periphery or its central connections, right? Now, how do you discern between the two? Well, you look for associated features. Okay, so in the central nervous system, the vestibular system is connected to the central nervous system. There are a lot of other anatomical structures there. There are cranial nerves, there are pyramidal tracts, there are cerebellar tracts. So the patients are likely to have other associated neurological symptoms. Okay, so therefore, always ask the patient whether you have double vision. Go through the cranial nerve checklist. Go through the limb checklist. Remember checklist again. So your dizziness, is it associated with double vision, numbness of the face, asymmetry of the face, slurring of speech, swallowing problems, weakness of the body, numbness of the body? If any of these symptoms are associated with vertigo, it's a central nervous system. And as far as ED is concerned, central nervous system vertigo, patient needs to be admitted. Okay, no need to go and scan. And remember, I said earlier, you're going to waste time, going to clog up your observation. The patient needs to be admitted. It's a central nervous system problem, right? Okay, so remember, look for central nervous system features. Okay, now then the next thing that you need to decide is whether the patient. Okay, so this is getting into a bit of the first part. You don't need to. I don't need to teach very much, right? Because you already know how to ask and examine the patient for cranial neuropathies and limb symptoms. Okay, symptoms and signs of central nervous system associated features. Easy. Then the next few minutes, I'll be talking about a few additional tools in your kit bag to help discern whether this is the vestibular system is affected in the peripheries or in the central nervous system. Okay, one of them is the type of nystagmus. Is it peripheral or central in nature? Now, in our context now, because you're in the emergency department, it's not so much, there's no need for you to go into the details of what is peripheral nystagmus and central nystagmus. So I'm going to skip through this. But I think some of you have gone through internal medicine before, would have heard me tell you how to discern how peripheral nystagmus comes about, using this diagram. But in the interest of time, I'm not going to go through all this. And I'm going to go to the final bit, which is basically peripheral nystagmus. The key feature is it's non-direction changing. Non-direction changing. Okay. Of course, there are other features like. Okay. But the key feature as an emergency department doctor you need to know is the nystagmus is unidirectional. It does not change direction. Anything that changes direction is not a peripheral nystagmus. That's the only thing you need to remember from an emergency department point. Okay. So, for example, this patient, okay, the nystagmus is beating in one direction. Of course, you notice that some of you would have seen me using this pair of glasses. Basically, it's, if you look at this, one of the feature of peripheral nystagmus is when you remove visual fixation, it gets worse. The nystagmus gets worse. And so one of the tools that we use at the bedside is use thick magnifying glasses to remove visual fixation, which of course is not available to you. So therefore, I'm not going to focus too much on it. So what I want to do is just focus on the key thing that's available to you, which is the nystagmus changing direction. Okay, always beating to the left for her. Whatever you do to her is always beating to the left. Okay, and therefore it is a peripheral nystagmus. If you look to the left, look to the right, look up, look down, it's always beating to the left. And of course, again, this patient again, when you put on the glasses, it becomes much more obvious. Okay. Okay, so these are the key features of peripheral nystagmus. Horizontal nystagmus, that's unidirectional nature, beating away from the side of pathology and always beating the same direction, and gets worse when the fixation is removed. Okay, so this is another patient that you may typically see, comes in with severe vertigo, vomiting all over you. Okay, after you cleaned up the vomit, you examine the patient's eye movements, and you realize that he's got a very subtle right-sided nystagmus. Then when you look to the right, it's still beating to the right. Then when you get the patient to look to the left, it doesn't change direction. It either disappears or continues to beat to the right. And again, like I said before, when you remove visual fixation, in this case, we did a very simple thing by just asking the patient to close the eyes. In this case, we're very lucky because the eyelids are very thin and you can see the nystagmus gets much more obvious. So all the key features are there. Horizontal nystagmus that beats away from the side of pathology, does not change direction, and gets worse with removal of visual fixation. Okay, so this is classic peripheral nystagmus. But from your point of view, I just want to keep it simple. Just remember the key feature. Nystagmus that does not change direction. Okay? Okay, so that's the key feature of peripheral nystagmus. Central nystagmus is just the opposite. Okay, again, I'm not going to go into it in the interest of time. What is the mechanism of central nystagmus? But the key thing as an emergency doctor you must remember is that it always changes direction. Always changes direction. When I look to the right, reach to the right. When I look to the left, now it's beating to the left. So what do you do with this patient? Admit the patient. No need to do anything else. Admit the patient. Because this patient requires evaluation. There's some central nervous system pathology. Okay. So likewise, this patient has got a central nervous system pathology. This case is Wernicke's encephalopathy. Unfortunately, it takes too much alcohol. It doesn't do anything else but drink alcohol. You know, and these patients require high dose of intravenous thiamine before anything happens to them. And see, when he looks to the right, he beats to the right. When he looks to the left, beats to the left. So this cannot be peripheral nystagmus. So anything you need to know about nystagmus is that any nystagmus that changes direction is central. Okay. So first set of information, very easy for you, right? Because you learn in medical school. Cranial nerve symptoms and signs. Limb symptoms and signs of neurological depth. If they are there, it's central. If they're not there, then go on and examine the eyes. If there's a nystagmus that changes direction, it's central. Okay. Then the next thing that your seniors in emergency department are taught, but to be fair, it's difficult for you in the 3 months you're posted there to learn this, but your seniors have been taught, okay, they'll be looking for something called a head thrust sign. The head thrust is basically a way of discerning paresis of your vestibular organ. So it's a peripheral sign. If it's positive, it's a peripheral sign, okay? Your seniors are taught how to do it, okay? So when you ask your seniors to come and evaluate your patient, they will come and do this, okay? I'll show you what a head thrust sign is. So basically what we do is we move the head very quickly from a primary position. So this is slow movement just to reassure the patient that everything is okay. Then after that, I move the head very fast, okay? If this is the patient's head, I move the patient head from the center to the left, and then from the center to the right, okay? Now during that time, the patient is asked to focus on the examiner's nose, or examiner's eyes. Now you can't see the nose because of the mask, so you ask them to look in your bridge of the nose or your eyes, okay? Now, the eyes should be fixated on the examiner all the time. That's a normal head thrust. If the eyes are not fixated on the examiner, it follows the head and then subsequently the patient does a catch-up then that's a positive head thrust. Okay. Now this must be consistent because many times in elderly patients, when you ask them to look at your nose or you look at your eyes, they're not interested. They're looking all over. Okay. So, but then in that case, sometimes you'll be there, sometimes you'll not be there. You'll not be consistent. But in patients like her, who's got one-sided vestibular paresis because of acute peripheral vestibulopathy, the head thrust is consistently there every time you move the head towards the direction. Now, how do you know that? The moment you move the head to that side, she loses fixation on your nose. When you lose fixation on your nose, when you get that feeling, head thrust is positive. Now, there's a bit of learning curve to it, and that's why I don't want to focus on this at this point to you. Okay, but you need to know what it is so that when your juniors, when your seniors do it, you know how to interpret it. Okay, let me show you how to do it. So first part is just to move the head left, right, just to reassure the patient. And after that, you move the head from the primary position to the left very fast. Normal. Normal. Now I'm going to do the abnormal side. And you'll know it's abnormal because, see, she was looking away. And then she does a catch up. Okay. The moment you see, why is she not looking at me? Then you know it's a head thrust positive. Okay, let's play it again. When I move to the right, she's still looking at you. Still looking at you. When I move to the left here is abnormal. And I move to the head to the left. Her eyes follow the head. And then she realized, oh, the instruction was look to the doctor's face, right? I need to move it back. And then you see this catch-up occur. This catch-up eye movements suggest there is a head thrust is positive. Okay? So it requires a bit of training. At the end of 3 months, you will get familiar with it. Okay? So, but I don't expect you to know it on first day, so first week or first month. Okay, but this is the best example I can give you. Okay, to the right, normal, normal. To the left, abnormal. So that abnormal. Okay, so now let's see whether you all can interpret which side is abnormal. So that clearly, when I moved the head to the left, his eyes were still looking at me. But when I move the head to the right, patient's right, the eyes follow the head first and then does it. Then he voluntarily brings back his head to that. Okay, so that's how you interpret that. Okay, so that is head thrust. Okay, so finally, there's your seniors will do something called a skew deviation. Skew deviation is something again, it's not difficult, but requires a bit of training. You sit the patient up. You need to sit the patient up. The patient can tolerate it. And then you realize, hey, one eye is up, one eye is down. Vertical deviation of eye is called skew deviation. Okay, this is a sign of central nervous system disease. Okay, so in other words, if the patient has signs and symptoms of cranial nerve deficit or signs and symptoms of limb deficits, okay, if the patient has got a gaze-evoked nystagmus, that means look to the left, beats to the left, looks to the right, beats to the right. That means direction changing nystagmus. And the head thrust is negative, no positive head thrust. And the skew deviation. All this suggests a central nervous system disease. Okay. Okay, later on we will tell you how this is put together in an acronym, but this is basically how you decide whether it's a central or peripheral disease. So summary again, cranial nerve deficits, limb deficits. Present or absent. Nystagmus, is it direction changing or not? Head thrust, present or not? Skew deviation, present or not? Okay, based on this, we decide the second question. Okay, the third question is very simple, duration of vertigo. Why? Because all the conditions that you see in dizzy patients, vertigo patients in the emergency department have either one of these conditions, and all of them, if you can get them to give you a good history, often the history is not good because they don't want to tell you as it happens. Is it few minutes, many hours, or variable? Okay. Few minutes each time it disappears. Few minutes each time it disappears. Likely to be benign positional proximal vertigo. Vestibular neuronitis is always many hours to 1 or 2 days, continuously going on for 1 or 2 days. Posterior circulation TIA is another differential diagnosis for vertigo, right? It's always ongoing. The rest of it is rare, so don't talk about it. Okay. Then the fourth question is also fairly easy. Is this the first episode of vertigo, or is it a recurrence of your previous spells of vertigo? Okay. Now, if it's the first episode, then you're dealing with either a recurrent disease that's coming to you for the first time, or you're dealing with a uniphasic disease. What are uniphasic vertiginous syndrome? Vestibular neuronitis is uniphasic. You never ever get recurrent vestibular neuronitis. Now, many of you will be a little bit disturbed because you would have seen patients with recurrent vestibular neuronitis. I'm telling you, categorically, they've been misdiagnosed. Okay? Vestibular neuronitis, it's a bit like Bell's palsy. Like it can be recurrent, but it's super rare. Okay? Because in Bell's palsy, it's inflammation of the 7th nerve. Now, vestibular neuronitis is inflammation of the 8th nerve, and it's associated vestibular system, usually viral. Okay? It's a uniphasic illness. Very unlikely for you to get it once in your life. If you get a recurrent, almost always the doctor is wrong. We are wrong. Okay? There's something else going on, was misdiagnosed. Or only it's very rare for you to have recurrent vestibular neuronitis. It can happen, but super rare. Okay? Okay, so it's almost always a uniphasic. On the other hand, if the patient says, doctor, actually, this is not the first time. I've been to Kutekwat, I've been to this, I've been to that, and you've seen me before also. Okay? You've seen me before also. So it's not a monophasic disease. It's a recurrent disease, very similar episode. Then we know that it could be a BPPV. Okay, if it's over the last few weeks, and TIAs are like a bit like angina. Patients don't get chronic TIAs because either you go on to develop a stroke or the TIA resolves because of the autoregulation in the central nervous system. Okay, so if it is recurrent over the last few weeks, it could be a TIA. Okay, positive circulation TIA. Or if it's been going on for many years, okay, in a young patient, it could be migraine. Okay, so that's how we look at the 4 questions. Now very quickly, I'm going to go on and give you examples of how we put the 4 questions together. Okay, first patient comes to you and says, doctor, I've got dizziness. Then you ask, is it spinning? Yes, doctor, it's spinning, and I'm vomiting all over you now. Look, I just messed up your scrubs. Okay, so clearly, question number 1, answer is vertigo. Secondly, you ask, patient, do you have any double vision, dysarthria, dysphagia, weakness of the face, numbness of the face? Okay, weakness of the body, numbness of the body. Yes, doctor, I have all of these. Clearly, the patient has central nervous system disease. Is it recurrent? Yes. Each time lasting many hours in the last few weeks. So this patient clearly has a central nervous system disease. Most likely he's going to go on to develop a major brain stem stroke. Patient needs to be admitted. Full stop. Nothing to argue about, right? Clear cut. Okay. Next scenario. Patient says, doctor, I'm giddy. Then you ask them what kind of giddiness? Spinning like crazy, and no loss of consciousness, no obtundation of sensorium, just spinning. And I'm vomiting all over you. Okay. But I have no diplopia. I've got no weakness of the face, no numbness of the face, no dysarthria, no dysphagia. I've got no weakness of the body. I've got no numbness of the body. Okay? It's the first episode ever, and it's been lasting many hours. Okay? Now, based on what we have, what could this be? There are 2 possible causes, but often doctors will diagnose only one. There's a bias. There are 2 possible causes. Because the second set of information is negative, but there are no central nervous system features. Doesn't mean there's not central nervous system disorder. Okay, so must be careful. So it could be in an elderly patient with vascular risk factors. This could be a positive circulation stroke, like a cerebellar stroke. Okay, or because sometimes cerebellar strokes, the patient may not have any cranial nerve deficits or limb deficits. Okay, or it could be vestibular neuronitis. But it's only these 2, only 2 differential diagnoses. Okay, between the 2 differential diagnoses, there are a number of ways to sort this out. Okay, we already told you there are some additional tools that I give you. Look carefully at the understanding, look for head thrust sign, and look for skew deviation. And this is the basis of your HINTS acronym that your seniors may have mentioned about. HINTS stands for, there's another way of changing the acronym to infarct also, but The original acronym is HINTS. Hit impulse, positive. Nystagmus in this patient is unidirectional, non-direction changing, and there's no skew deviation. Okay, so what does that mean? Remember we said okay, this patient has got vertigo, no central or peripheral features. First episode lasting many hours. I remember it. Two differential diagnoses: vestibular neuronitis versus stroke, posterior circulation stroke. And I told you now, the head impulse is positive. Nystagmus is of a peripheral nature because it does not change direction and there's no skew deviation. So what does the HINTS point towards? Points towards a peripheral cause. So this is vestibular neuronitis, and this patient does not have a stroke. Okay. The reverse of this is that this same patient, sorry, backwards in the slides. Okay, this same patient who's got vertigo, no central or peripheral features. First episode lasting many hours. Okay, when you apply the HINTS, the head impulse is negative. The nystagmus is direction changing. And the skew deviation. Okay, that means the HINTS is pointing towards central nervous system pathology. What are you supposed to do with this patient? Admit the patient. Full stop. Why? Because this patient has got a second diagnosis, which is posterior circulation stroke. Now, in fact, the data clearly says that this patient has a stroke regardless of what the MRI shows. So no point wasting the time sending the patient for MRI. Okay, once the head impulse is negative, the nystagmus is of a central nature and there's skew deviation, this patient has got a posterior circulation stroke. Because this HINTS protocol is much more sensitive than even the MRI in an acute stroke setting. Okay? The studies have clearly shown that even before the MRI shows the stroke, the HINTS shows the stroke. So this patient needs to be admitted anyway. So might as well admit the patient. Okay, if you can do the scan, good, but don't clog up the observation. Just admit the patient. Okay. On the other hand, if the HINTS protocol points to the peripheral pathology, HINTS protocol provides points to the hip, then gives you a very high index of suspicion that this is not stroke, this is vestibular. So you treat the patient as vestibular. Okay, so that's the basis of the HINTS protocol. Okay, so we've gone through two sets of possible permutations. Now we come to the third permutation. Patient has got vertigo because he says spinning and vomiting all over. Again, he's got no diplopia, no numbness of the face, no weakness of the face, no dysarthria, no dysphagia, no other symptoms. Okay. This time he says, doctor, is recurrent. This is not the first time I'm coming to you. Many times I'm coming to you. And each time is very, very short periods. Okay. Now, two differential diagnoses again. With central nervous system, this could be a TIA, but we know TIAs cannot be chronic. Must be short periods. So if he says, doctor, I've been having recurrent spells for the last 3 weeks, then consider this as a TIA, okay, which means the patient may need to be admitted for evaluation. Or the differential diagnosis is benign positional paroxysmal vertigo. Benign positional paroxysmal vertigo, which is a very common disorder in the elderly patients. Okay, almost as common as TIA. So therefore, you need to know it well. Okay, so BPPV versus TIA. BPPV happens recurrently over a period of years and months. Okay, each spell characterized by multiple short spells, while TIAs will be recurrent but over a very short period of time, maybe the last 2 to 3 weeks. Okay, but the diagnostic test is your Dix-Hallpike maneuver, okay, which is what I'm showing you here. Now, because this is a virtual tutorial, we won't be able to talk about this very much. But I've given you in your notes various YouTube videos for you to go and learn how to do it. Now, benign positional proximal vertigo of the posterior circulation, benign positional proximal vertigo of the posterior canal, BPPV, is very common in the emergency setting. So you need to know it well. Okay, this is the Dix-Hallpike maneuver to diagnose it. So you need to know this maneuver. Okay, this Dix-Hallpike maneuver you need to know because it's common. Whether you're an ED physician, general physician, GP, you need to know this maneuver. So go and learn it. Okay. There's a session that I conduct with your seniors, practical session where we teach, where you go through them, the procedures. If you're interested, you can attend them and learn it. But it's not difficult. You can just watch the videos that I've sent you and learn how to do it. Okay. If these tests are positive, it's BPPV. If these are negative, then you have to consider the differential diagnosis of a TIA in an elderly patient with vascular disruption. Okay. Now, BPPV, the common one is posterior canal BPPV. Posterior canal BPPV, which where the dick sulfide maneuver, which is what this student is doing. Again, the magnifying glasses here help you see the nystagmus. So once you put the head down, there's this fierce eyebrow beating nystagmus. Okay, when you see that, your diagnosis of BPPV is confirmed. Okay, this is the commonest type, but there are other rarer types. Okay, okay, like for example, this is the horizontal canal BPPV. Leave this to us. As a ED physician, you don't need to worry about it. Okay, because these are not common. Okay, you don't have time to go through all these maneuvers. Okay, so don't worry about this. But the videos are given to you so that you are comprehensive. You don't have to worry about it. Okay. Now, once you've diagnosed this condition called benign positional proximal vertigo, the therapeutic maneuver which your seniors know how to do is the Apley maneuver to correct the patient.
Patient's head is then brought down.
This is the Apley
One
maneuver.
looks for the nystagmus. This can usually be done with Fresnel lenses. Then the patient's head is turned about 90 degrees toward the other side.
Okay, this is that therapeutic maneuver to fix BPPV. Again, I will not teach you this now because this is a virtual tutorial difficult. In the practical session for your seniors, I teach them, so your seniors know how to do it. If you diagnose BPPV, you must do this. No point letting the patient suffer because benign positional proximal vertigo is a benign disorder. Once you do this, normally what we do is we discharge the patient immediately. Okay. And then sometimes we get them to come back to the vestibular therapist for follow-up treatment. The vestibular therapist does the same thing. If the first maneuver was unsuccessful, they will repeat it again and again until the patient is successful. Okay, this treatment is evidence-based treatment. It works well, so you must learn how to do it. If you can learn, sorry, you should learn how to do it if you can, but your seniors know how to do it. Okay, I'm not going to insist that you learn how to do it within the 3 months. But you can start learning how to do it and learning how to do it using the videos. You don't have to learn all the maneuvers. You only need to learn the Apley maneuver for the most common form, which is the posterior canal benign positional proximal.
Right position.
Okay. Okay, so the videos are all there for you to go and learn. Okay. Now, final scenario is a patient who comes to you for spinning, vomiting all over you. Again, the patient says it's got no central nervous system features. It's recurrent, but each time it's lasting many hours. Many hours. It's been going on for years. Okay, these patients are often misdiagnosed as recurrent vestibular neuronitis, recurrent, sometimes misdiagnosed as Meniere's syndrome. Okay. Now, Meniere's syndrome is an important diagnosis to consider in these patients if they have associated hearing loss. But Meniere's is rare. Okay. But what's much more common, and this is most likely the cause for this, is migraine. Okay. Remember, we talked about migraine earlier on. In migraine, the headache is very prominent. But sometimes migraine patients will tell you that for this particular spell, the headache wasn't very prominent. But my motion sickness feeling, the nausea and vomiting is much more prominent. And this feeling of disequilibrium. Okay. So the commonest cause of a young patient presenting to you with vertigo lasting many hours, recurrent for many years, is migraine, and terribly underdiagnosed in the community. And that's why the International Association for Headache has come up with this criteria for you to diagnose migraine. Sometimes people like to use the word vestibular migraine to make it clearer so that people don't misdiagnose them. But always think about patients who they already have migraine, but in this particular spell, the headache is not so prominent, but they're presenting with recurrent episodes of just dizziness. Okay. Now, what if the first question? So that's how you approach the 4 questions. But what if the first question, the patient says, "Doctor, I'm not spinning at all. I'm not spinning at all. I'm having a sensation of faint." sensation of pain. I'm going to like everything become dark. The voice is getting very soft. Get this ringing sound in my ears, and before I know it, if I persevere with this, I'm going to lose consciousness. There's no spinning feeling, and there's no nausea, and there's no vomiting. Okay, so this is a not vertigo feeling. So that means your first question was not vertigo, syncopal feeling. So how do you approach it? Okay, now this is very common in the emergency setting, very common in general physician medicine. It's due to transient hyperprovision of the brain. Okay, so how do you approach it? Actually, there is a checklist. The checklist is based on a systematic approach of what supplies blood to the brain, what supplies oxygen to the brain. Okay, it won't take long for me to cover this, because if you think about it, it could be a problem in the blood pump itself, right in the center, the blood pump. Okay, the heart is abnormal. And the problem could be either a rhythm problem or a flow problem. Rhythm problem would be things like your heart blocks, your ventricular tachycardias, your prolonged QTC intervals that cause ventricular tachycardia, prolonged PI intervals, all these things that predispose to patients having intermittent episodes of cardiac dysarrhythmias. Or the problem is not a rhythm problem, but it's a flow problem. The patient has got hokum. The patient has cardiomyopathy. There's transiently the flow, especially when they're exerting themselves. A young man is playing basketball, jumps, because he's got hokum. The flow is not so good. Okay, transiently the flow drops, he loses consciousness. Okay, so think about that. When you think about that, you're less likely to get into problems, because you will do that relevant cardiovascular examination to look for cardiac pathology. Once you've sorted out the heart as the source of the problem, the next is what's wrong with the blood. Because if the transient hyperprovision to the brain is not due to the heart itself, maybe it is the blood itself that's abnormal. The blood abnormality are a myriad of causes, mostly genomedical. Hyponatremia, hypoglycemia, hypercalcemia, hyponatremia, hypernatremia, sepsis, all the genomedical geriatric causes that causes Tong Gong in the elderly patients who are coming. Okay, so think about blood, anemia, of course, polycythemia, anything that's abnormal in the blood that causes the blood flow to the brain or the oxygen to the brain to transiently or persistently be reduced. Patient will complain of syncopal dizziness. Okay. Now, if the blood pump is normal, if the blood is normal, maybe it is the pressure that's transmitting to the brain is abnormal. So that's when you talk about low pressure. Low pressure, of course, could be persistently low in all your sepsis syndromes, in your trauma, in your patients with bleeding GIT will come to you with dizziness. Actually, they are melenic. They are having melenic stools. So clearly, they are low pressure, and that's why they are complaining of dizziness, right? Lightheadedness. And if you don't treat the melena, don't treat the bleeding GIT, then they're going to faint on you. Okay. Okay. But more commonly in general medicine, you get patients with episodic low pressures because they are over-treated with blood pressure medicines. They have transient hyperperfusion due to postural hypertension, or they have some kind of autonomic dysfunction. Okay. Most common cause is over-treatment with blood pressure medicine. So think about that. So recap. The transient hyperperfusion of brain could be due to problem in the heart, due to the pump, due to the rhythm. If the pump is normal, the rhythm is normal, then think about the blood. If the blood is normal, think about the blood pressure to the brain. And then rarely, the blood vessels to the brain. As I said before, blood vessels to the brain, because there are 4 blood vessels to the brain. Very rarely they cause dizziness unless critically all blood vessels are normal or the basilar artery is abnormal. So occasionally, when the blood vessels to the brain is abnormal, like the stenosis, the patient can present with a syncopal or syncopal dizziness. But more often than not, they're going to present with TIA, stroke-like symptoms, or vertiginous dizziness. Remember, posterior circulation TI. So rarely, posterior circulation TI can present with syncopal or dizziness. But more importantly are the first 3 causes there. Blood, the heart, cardiac causes, blood causes, and the blood pressure causes. Okay. Then finally, we have this physiological condition called neurogenic syncopal feeling or vasovagal syncope. Okay, which is very common in emergency setting. Okay, it's so common that you should have a lecture on its own now, because it's so common for you to see faints in the emergency department. These are benign veins that are occurring in young people, okay, so-called vasovagal syncope. And usually there's usually something that indicates that this is vasovagal syncope. Okay. So usually these are young patients who tell you that they have a chronic history of recurrent veins. Usually there is something noxious that induces the symptoms. Almost always they are either sitting or standing. It shouldn't happen when you're lying down. Okay. And often there is a premonition that tells you you're going to faint. Usually it is a combination of factors like, no, I didn't take breakfast, it's a crowded place, I was stressed, I couldn't sit down, I was having abdominal colic, I was having menstrual cramps, it was a crowded train, I was standing, and then before I know it, I'm feeling very dizzy. Because I couldn't lie down, because it's a crowded train, I fainted. That's a classic story of a vasovagal syncope. Okay, so look out for all these things. Now, it's important that you look out for all these things because if you think about what I just said earlier, patients who come to you with a faint can be any of these things. It could be a cardiac dysarrhythmia, it could be a cardiac outflow problem, it could be a hypotension, it could be anemia or blood-related problems. It could be any of these things, right? But it could also be a benign condition called vasovagal syncope. So if you don't go through this checklist, you could either overdiagnose serious condition or underdiagnose serious conditions and end up with errors. So it's important for you to think about, like we said before, go be systematic about it. Think about the heart pump, arrhythmia or outflow problems. Think about something wrong with the blood and all the things that can go wrong with the blood. Think about things that are causing hyperperfusion to the brain because of hypotension, either persistent or intermittent. And then think about possibly a blood vessel problem, but as I said, that's not common. Okay, usually blood vessel problems present like a TIA. And then finally think whether this is a benign physiological condition called vasovagal syncope or benign faint. Okay. Okay. So usually there's some positive diagnostic features as well as rule out. Those things that I mentioned earlier, all the rule out features. Now you think about all the positive features, which is usually young patients, they have a history of recurrent fainting spells. They have noxious stimulus that started off. They're sitting or standing. There is something queasy that made them uncomfortable, like venipuncture, seeing a lot of blood, they're seeing something very unpleasant. And then there's a premonition. And if the premonition was aborted, they would have been okay. But unfortunately, sometimes the good Samaritans come along and hold them up, and therefore they cannot lie down. Because once you lie down, vasovagal syncope is corrected. Because this is a normal reflex. In fact, it's very interesting. This is actually an evolutionary remnant of our play dead phenomenon. So it's interesting that our evolutionary ancestors had this reflex that when you know you're going to die for sure because you're surrounded by predators. Okay, your vasovagal tone goes down, your vagal tone goes up, your heart rate drops, your blood pressure drops, and you look like you're dead. Okay, and that gives them an evolutionary advantage because predators don't like to eat dead animals. Okay, if you don't believe this exists, you can try it on the cockroach. Cockroach is well known to do play dead phenomenon. Kids, you may have noticed it. You think that you have crushed the cockroach, you hit the cockroach, walk away, and a few hours later come to clear it, and then it's gone because it pretended to be dead, and then because it pretended to be dead, you didn't completely crush it. You walked away, right? Yeah. So the same thing happens. This particular trait is retained atavistically in the evolutionary chain, but in humans it's become a nuisance. Why has it become a nuisance? This paper suggests that because for humans, because of our erect posture, the brain is above the heart. In all animals, the brain is in level with the heart. So the vasovagal syncope only kicks in a very, very severe situation, like being surrounded. If you're let's say you're an antelope or something, you're surrounded by a pride of lions. You're not going to die for sure. So might as well, cannot run. So might as well pretend to be dead for a while and hope that the lions will walk away. Okay, and in significant number of times, the lions did walk away for this gene to be propagated. But for humans, it's become a nuisance. Why? Because our heart is below the brain, and therefore, even when it's not a noxious stimulus, like, menstrual cramps, you didn't eat breakfast, you're going for your exams on the day, you're traveling in the train, crowded train, everybody is making a lot of noise, and then you're feeling very hungry, and then the cramps come in, and you cannot sit down, the blood pressure drops, heart rate drops. So the way to abort it is to quickly recognize it, quickly lie down, right? And then you would have been okay. Because once you lie down, your heart is at the same level as the brain. Hydrostatic force would have regained the cerebral heart. So it's important for you to recognize this as for its positive features, in addition to ruling out all the other causes of faint. Remember, the fainting could be due to cardiac causes, due to blood pressure causes, or blood causes, right? Okay. So rule out all those things, but also rule in these causes. But this is super benign. All those things are sinister. Okay. So therefore, it's important for you to think about rule out and rule in features so that you make the right diagnosis. Okay. So in summary, dizziness is a complex problem. So don't use intuition like patient feels well, it looks like peripheral, it looks like sun. All this is the dark side. Okay. So ignore it. Use your voluntary part of the brain, formulaic part of the brain, to use a 4-question approach. Is this vertigo? Is this dizziness vertiginous or syncopal? If it's syncopal, we said it could be cardiac, blood pressure, or blood-related problem, or a benign problem like vesicular. If it is not syncopal dizziness, okay, is it vertigo? If it's vertigo, look for associated central nervous system pathology. Okay, somebody can mute themselves, please. Is it a central nervous system pathology? If it's not a central nervous system pathology, sorry, I got distracted by the sound. So, okay, if it's vertigo, then you realize the second question is, are there central nervous system pathology? Okay, so that is part of your basic medical training. But today we told you the one way to sort out central nervous system pathology or absence of central nervous system pathology is the HINS protocol, which is the presence or absence of headache pulse, the presence or absence of nystagmus that's characteristic of central and peripheral disorders, and the presence or absence of scheme. Okay, so one additional tool to answer this question of whether this is CNS pathology or not, in addition to your standard neurological exam and history taking. Okay. Then the next question is whether this is a recurrent episode, and the last question is whether this is a short one or a long one. So based on that, then you can decide whether this is a peripheral pathology like BPPV, vestibular neuronitis, or central nervous system pathology like stroke or TIA. Okay, and then just like what we said for headache, depending on your pretest probability, you do the appropriate thing. And appropriate thing may require you to image the patient or to do the relevant investigations to confirm or refute your diagnosis. Okay, I'm going to stop here for questions. Okay, if I'll remain for another 1 minute. The rest of you can follow. But if you have questions, you can stay on and ask questions. And I can send out the recordings to your secretary later. Okay.
Thanks, Prof.
Thank you for your attention and have a good weekend.